Hi, everyone, and thank you for joining us for today's webinar, Preparing for Practice in Canada, Ethical and Cultural Perspectives for IMGs and ITPs. Bonjour à tous et merci de vous être joints à nous. My name is Meredith Dalt, and I work in communications here at the Medical Council of Canada, and I'm going to be moderating today's discussion. So at the beginning of business meetings in Canada, it's become common practice to acknowledge the fact that we live and work on Indigenous lands. So we're going to do that today. We do it in the spirit of reconciliation. And so I want to begin by acknowledging that the Medical Council of Canada is situated on the territory of the Anishinaabe Algonquin Nation, who continues to care for and sustain the land on which we gather, work, and play. Before I get started, I want to remind you that today's webinar is taking place in English, but Zoom does provide a simultaneous translation feature. So you can choose to see the captions in a number of different languages, including in French, and there are instructions on how to engage the live translation in the chat window. Tout au long du webinaire, vous pouvez activer la fonction de traduction simultanée pour afficher les sous-titres dans la langue de votre choix, dont le français. Les instructions sont affichées dans la fenêtre de clavardage. Please note that this is AI-generated translation. It's not 100% accurate, especially with acronyms and with proper names. Cette traduction est générée par l'intelligence artificielle et certains termes pourraient ne pas être conduits correctement, surtout les acronymes et les noms propres. You may ask your questions in either English or French, but all questions are going to be answered by the panel in English. Vous pouvez poser des questions en français, mais vous recevrez des réponses en anglais. So just by signing up for today's session, you are going to be receiving a recording of this webinar by email. We're also going to be sending a version with more accurate French translation in a few weeks, so keep your eyes on your inbox for that. We have a great panel of experts for you today, and I hope that you're going to take the opportunity to engage with them and engage with one another, as I see some of you are already doing in the chat. If you want to ask questions, and I hope that you will, we're not too big a group yet, and so I want you to use the Q&A button at the bottom of your screen to ask questions. So do not use the chat for your questions to the panel. Please use the Q&A button for questions to the panel. The chat, however, is going to be a space where you can converse with one another. I want you to please keep your conversations kind and respectful, and note that questions you ask in the chat box, again, I want to stress this, will not make it to the panel. So use the Q&A button for that. And I know I don't have to remind you of this, but I do remind you to just be respectful, and then don't share confidential information like candidate numbers, for example. And now it is my pleasure to introduce our panel. Our first speaker is Dr. Armand Aalamian. My goodness, he's used to people butchering his name, which is Aalamian. He's the Executive Director of Safe Medical Care and Equity, Diversity and Inclusion, or EDI, with the Canadian Medical Protective Association, also known as CMPA. Dr. Aalamian is also a nationally recognized leader in medical education in Canada. Prior to joining the Canadian Medical Protective Association, he spent 2 decades with McGill University's Faculty of Medicine as an associate professor, and also held various leadership roles, including Associate Dean of Postgraduate Medical Education and Family Medicine Program Director. So he knows a few things. In addition to this work in medical education, he has practiced medicine for over 30 years, holding various positions such as Chief of Mental Health Services with CSS de la Montagne Community Clinics and Chief Medical Consultant at the United Nations International Civil Aviation Organization. He has substantial experience in collaborating with national and international medical education stakeholders, and as an accomplished leader, has promoted safe medical care, cultural humility, equity, diversity, and inclusion within healthcare organizations. Armand, we're very grateful that you're here. Sorry to make you listen to that bio about yourself. Our next speaker is in Newfoundland and not online at the moment because they are having nasty weather. And so Dr. Lucy Shantel Nakibuuka will be joining us as soon as she is able to. And I'll introduce her when she joins us. In the meantime, I do want to introduce everybody's favorite, Dr. Filipe Santos. Some of you will have encountered Dr. Santos in previous webinars. Dr. Santos is an IMG consultant with the Medical Council of Canada. He's also an anesthesiologist and assistant professor at the University of Toronto, where he serves as simulation lead and fellowship coordinator in the Department of Anesthesia at St. Michael's Hospital, Unity Health, Toronto. After completing his MD, residency training, and a PhD in pharmacology in his native Brazil, Dr. Santos moved to Canada in 2017, where he pursued additional postgraduate training and earned a Master of Science in Community Health from the Dalla Lana School of Public Health. Drawing from his personal experience as an internationally trained physician, he is deeply committed to advocacy and mentorship in medical education and licensure. He's also the author of the ebook Physician Licensing in Canada, which is available on the MCC website. Armand, Filipe, I'm really grateful you're both here. Hopefully Lucy will be joining us as soon as she is able. But I wanted to start, and thanks audience. It's great to see you engaging in the chat. Keep it up. Armand, I want to start with you. I want to give you each a little bit of time to situate yourselves for our audience. Share your own perspectives, experience with the topic. So Armand, let's go with you. Just so we're all on the same page. Help our audience understand something about what the Canadian Medical Protective Association, or CMPA, does and how that informs the perspective that you're bringing to today's conversation.
Thank you very much, Meredith. And it is absolutely delightful for me to be here as a panelist with my distinguished colleagues. And what a wonderful, wow, I'm looking at the chat, Meredith, and seeing all the folks that are joining us from all over the world and all over Canada. And it's just absolutely delightful. So I'm going to take just maybe a minute to tell you who we are, and so that everybody, regardless of where you're coming from, can sort of identify with this organization. We are a mutual liability protection organization, Canadian Medical Protective Association. What does that mean? That means that every physician, all 116,000 physicians and residents in Canada, are members of our organization, and they get liability protection from us when they practice medicine. So what does that mean is that we promote safe medical care. We identify medical legal risk. We identify issues that go wrong in care. And we do tremendous amount of research. We look at data. We have the world's largest physician medical legal database. And we turn that into a variety of different products, their offerings to reduce medical legal risk and promote safe medical care. We are also there for physicians when they need advice, when they need protection, when things go wrong in medicine. And anybody who's practiced medicine knows that things do go wrong sometimes in medicine, unfortunately. So we're there to provide that kind of protection and support to them. And I come here today with, as you described, and you're very kind in the intros, with a lot of experience that made me humble in terms of understanding the complexities of the issues that we're discussing today and the humanity behind it and the importance of having the kind of conversations that we're having today in understanding what these different contexts are and how we can approach it, how to provide better and safer care to all patients. And to me, that's really the core and the foundational reason why we're there, and what I'm really excited about this conversation today and having the exchange with the wonderful people who are online today and my fellow panelists.
Thanks, Armand. Actually, while I have you on, while you have the floor, can you speak to the fact, does the CMPA cater to both internationally trained physicians and also Canadian trained?
Yeah,
Do you find it sort of equal?
Yeah, thanks for asking that question. So actually, Canadian international medical graduates, and that is a very heterogeneous group within the Canadian context. When we say international medical graduates, one of the things we have to be really mindful of is folks come from different backgrounds, different nationalities, different educational foundations. So this is a very, very heterogeneous group with lots of different, lots of diversity and lots of different strengths that's brought forward. And in terms of the Canadian context, 28%, almost 30% of our members are international medical graduates, which means that they've done their training elsewhere outside of Canada, who come to us within the Canadian context. And it is the fastest growing segment of our membership, international medical graduates for the CMPA.
Wow, that's fascinating. Thanks for sharing that. Um, okay, I've got so many more questions for you. We're going to go to Philippe. We don't have Lucy yet, unfortunately. So those of you waiting for Lucy, we hope she's coming. But Philippe, I was hoping that Lucy would speak a little bit to her own experience of having been an internationally trained doctor, which is in fact what you are as well. So you arrived. Oh, wait, we have a Lucy. Let's jump. I'm going to keep you focus on you, Philippe, and then we'll go to Lucy. But you now play quite an active role in supporting others who want to practice medicine in Canada. What was your experience when you first arrived of sort of navigating that ethical cultural landscape that we're talking about today when it came to practicing in Canada?
Thanks, Meredith, and hi, everyone. Sorry, I didn't even introduce. Thank you, Meredith, for the introduction, but I didn't even say hi to everyone. So yes, I think that every IMG has that moment where they start practicing in Canada, that they need to take a step back and pause and realize that they're not in their home country. So even to me, that first contact or that first experience was in things as simple as just observing how other anesthesiologists were discussing risks of procedures with patients and while obtaining consent. Brazil, for example, has a culture where people don't really want to know everything that can go wrong in a surgery. They feel as if it's a little bit of bad karma, as if you're trying to say it's going to happen, that if you say it's bad luck, and also they are very afraid sometimes. So, if you tell a patient going to a spine surgery, they're going to be face down and that there is a potential risk of vision loss, even though it's extremely, extremely rare and I never saw it clinically. Here we have to mention that, and it's expected by the patients that we will say that. It's expected by our laws and our practice that we say that. In Brazil, it would be extremely unusual. So, for example, as an anesthesiologist, I never had mentioned in Brazil that during intubation or laryngoscopy, I could break someone's teeth because it's very low risk. But here, I see it every day. So I had to learn how to adapt to the Canadian practice. And I think that we will go over many topics today, but I think that process can be the learning curve can be faster when you have more support. I had the luck of being and the opportunity of being in an academic institution where I have faculty that are experienced in helping IMGs do that transition. But I've also been in contact with a lot of IMGs that are put into situations where they do not have that support and they struggle. And as Dr. Armand Aalamian mentioned,
Just Armand, Filipe. Armand is fine. Really, just Armand is good. Yeah.
It translates also to safe patient care, right? Because I think even how people perceive care is also a matter of patient safety. If they're reassured that the care they're receiving is the best possible. So, it's important that the patient feels that they had all their risks explained to in the way that they think is appropriate. So we have to learn a little bit. We have to understand that, what might have been uncomfortable conversation back home is the commonplace here. And we need to move into that comfort zone ourselves. And that takes a bit and takes effort. So the more resources, the more help you can get, the faster that transition can be. And the best it is not only for the physicians, but also for the patients receiving their care.
Yeah, that's great. What do the people who talk to you, the people that you support, tell you about the challenges that they're facing when it comes to navigating these competencies
Yeah.
that we recognize are beyond typical clinical training?
Yeah, so I think one of them is obtaining consent, explaining risks, truth telling, so how much information you share about someone's care. Again, culture plays a huge role in this. Patient autonomy. Here in Canada, we're way more patient-centered. Patients have way more autonomy than traditionally is experienced in other cultures, which is extremely important to respect and to make sure that its respect is enforced. Similarly, just the fact that that the patients expect a certain, there is a certain how do I say this, the way that the people do medicine. So for example, one of the things that I was surprised and arrived, and a lot of people haven't shared this with me, is here we always ask permission to perform a physical examination. We always ask if the patient's okay, if they're comfortable. And I thought that extremely funny even when I arrived, because I'm like, if someone came to the doctor and didn't want to be physically examined, like, and I'm not talking about gynecology or urology or a private examination. I'm talking about a regular physical examination such as a chest auscultation, or even like examining and like asking them to open their mouth or something like that. We always present ourselves, we say what the physical examination is going to be. We ask permission, is it okay if I perform a chest auscultation? And I thought it was so funny. I would even tell to my Canadian physician that I'm like, well, it's like going to the barber and them asking if they can touch your hair. Like, why am I there if they're not going to touch my hair? And I really thought at the beginning it was like, didn't make sense. But it is a curve I learned, and it is how we perform medicine here. And it's extremely important that we respect that the patients actually, because the patients expect you to behave that way. And it is how, our regulations or policies are written, and we need to be the ones adapting to it and not the other way around. So I do get a lot of IMGs that share with me these experiences, also around confidentiality and privacy. Canada is extremely strict, as it should be, around confidentiality and privacy. And a lot of us, not because we don't think it's important, but because we were trained in a system that did not have the ability to do such enforcement, to have the means for that kind of enforcement. We're not used to it. So like I did not have back home, at every corner of the hospital, places to shred confidential information. Like, this is extremely important, but here it's available. But if you work in a hospital back home that does not have that resource, and how they dispose of that trash or that information that is confidential in a different way with the specialized companies like that, this is a resource that is resource intensive, and it's not available in other countries. So you have to learn that if you're going to shred any kind of hospital document that has patient information, it needs to be shredded appropriately in a confidential manner. And you can see newspaper articles that when this doesn't happen and people forget documents in the TTC or in the train, or it's in a regular garbage found by someone, this is a huge issue. The CMPA has to come into play, as everyone would say. And we also have to email all of them and disclose that there was a privacy breach. So all of this is a learning curve, and those modules that we do before we start a job or residency about privacy helps, but it's not enough. You really need to see it in action and get used to it.
Meredith, if I can just build
Yeah,
on,
please.
because I don't. Oh, Lucy's here. Do you want to go to Lucy before I build on?
I don't see her yet, but Lucy, are you here?
I am.
Oh,
Yeah.
hi,
So maybe
Lucy.
we'll meet Lucy and then I'll talk.
Let's meet
Let's get
Lucy.
to
Okay.
Lucy. Yeah.
Lucy, we've just been sort of getting ourselves situated in terms of the kind of lenses we're bringing to this conversation. I wanted to introduce, well, firstly, I should probably introduce you. That you are the manager of Policy, Advocacy, and Research Committee with the Internationally Trained Physicians of Canada, otherwise known as ITPC. But you're also an internationally trained physician with more than 10 years in primary care and primary care dermatology. And you got your undergraduate degree at Makerere, I'm probably saying it wrong, University in Uganda. Say it properly for me.
It's Makerere University. So you're
There we go. Makerere University in Uganda. And then you went and got your postgraduate training in primary care dermatology at Cardiff University in Wales. And then, where you're calling from now, you're in Newfoundland, poor thing, enduring a storm, where you got your Master of Public Health from Memorial University in Newfoundland. And so I wanted to bring you into this conversation because I know that when you arrived, you had some challenges in navigating the landscape, especially in these more sensitive ethical and cultural areas. Do you want to kind of give the audience a little bit of your situation? And yes, people are saying your camera's not functioning. I think you're on the phone. Is that
I
the
think
case?
because of the connection, like, I've had to connect through the phone. So I'd rather be present and speak, and hopefully, like, I'll work everything out.
Okay.
But like you said, I came from East Africa. I had that experience coming from Uganda, practicing. I had that clinical experience from Wales. And, when I came here, it was quite isolating, right? So, and I had to quickly adjust to the Canadian context, to the Canadian healthcare system, to understand things that we don't usually prioritize back home, like maybe what does really informed consent really mean, things like that, patient communication, being patient-centered, where most of our consultations are maybe doctor-driven. So those are things I had to learn and to factor into mind, really, to adjust to the Canadian healthcare system.
Okay. I remember you and I have talked about this, but tell the audience a little bit about maybe some of those cultural challenges you remember encountering. Do you have any examples?
Um, I it it was really tough in the beginning. Trying to knock on doors, trying to find information, getting scammed.
Oh, getting
So
scammed. I'm writing that down because if there's anyone in the audience nodding along, getting scammed, quickly tell us about getting scammed.
So, I mean, I was Newfoundland is quite isolating. So finding other ITPs was hard. So I had to go on the internet, and there's all these people offering courses, right? And they'll take advantage because you don't know. And some will tell you, okay, $100 a class or $30 for something that's not there. And sometimes you're in too deep and you're getting false information. So that kind of wastes your time as well. Um, so in terms of just getting situated, it was really, really challenging. And that's one of the reasons I joined ITPC, because I know it's a very isolating journey, and I wanted to turn my challenges into something constructive by helping other people who are coming behind me. So that's one of the reasons I'm with ITPC.
Okay, that's great. And just quickly for the audience, how does ITPC support people?
So ITPC is run by international physicians, and they offer mentorship, they offer resources, they offer practice interviews, basically anything you need to license in the Canadian healthcare context. So we do a lot of that, and I think I'm going to talk about it in the end because it's quite
Okay.
detailed.
And we'll be sharing some resources. I just wanted people to understand the lens that you were bringing to the conversation. Just before you joined, Lucy, Armand had something to say. I'm going to go to Armand unless he wants a question, but I think he's poised to tell us something he wanted to tell us.
I am. I was poised to say something. I just wanted to build. Filipe did an excellent job, and Filipe and both Lucy did an excellent job at raising some of the things that we see at the CMPA that like I said, we deal with all physicians across Canada, and some of the things that you raise are really important in terms of consent, in terms of privacy, in terms of cybersecurity. That's another issue that's becoming really big in Canada, and something that we're thinking about in terms of really looking at the standards of care. But one of the things that I wanted to highlight, although those are some of the common themes, and I'm going to call that our medical culture. So we have a medical culture that's really important. That's sort of we have to think about. But our country is for those of you who are in Canada, or those of you who are not, would know this, but those of you who are perhaps looking in, a very diverse country with many different cultures within the country. And some of the things that I've heard from international medical graduates are some of the challenges facing them when they're moving from province to province, because provinces have different regulations. They have different ethical standards that they're commonalities, but they're also differences. And I think that's the challenge and exciting to get to know those differences and needing to understand that when you're facing a patient, you bring in your own culture, you bring in your own values, you bring in your ethical background, as Filipe pointed out, some of your experiences. The patient brings their own. I work in a community clinic for about 25 years where we had 132 different nations being represented from different countries that would come and multiple languages being spoken on any given day. So the patient brings in their culture and their background. And then there's a medical culture that is also underlying it with the ethical and legal obligations that sort of bring in out the background. So all of these are interacting at the same time. And it's really important to shift into that frame of thinking when you're practicing Canada and the fact that you have to be navigating these different realities on any given circumstance. And you always have in the background your medical, legal, ethical obligation, and they all sort of intertwined within the Canadian context, that importance, and that's something we're going to be talking about further on.
Well, so while you have the floor, Armand, can you give us some examples of where we see internationally trained candidates struggling or getting into trouble when it comes to sort of ethical, cultural challenges? Are there, I suppose with a hugely heterogeneous group, as you say, you're going to see lots of different things, but are there areas you want to point to right off the bat?
Sure. I'm going to point out to the same to where we see international medical graduates get into challenges from our data, which are very similar to where Canadian graduates get into challenges within our data as well. They're actually pretty much similar. They're about the same. So where are some of the challenges? It is about, and within the context of today's conversation, around communication, around really understanding context, around consent. That's another one. Filipe pointed that out. That's a big one for us. Around documentation. That's another one. That's a very different way of documenting an encounter and the process and the thinking and rationale behind your decisions. Those have to be really clear within our context. And that's where we see some of the challenges. And I think the biggest challenge that we have had some, again, qualitative studies and spoken to many international medical graduates within the Canadian context. One of the things that comes across is around integration into the system, into the medical system. So that initial phase of coming to the country and integrating into the system can be challenging and really important to have the right supports in place when that is happening. So those are some of the big buckets where we see some of the challenges, Meredith.
So I guess what I think the audience is going to want to leave today with is some sense of how to bridge those challenges. Because what we're saying is these things aren't necessarily taught in medical school, especially if you're trained in a different country with a different cultural context. Let's just get into it. Like how do people get the education they need to be able to be successful in exams and in practice? Filipe, you're nodding. Lucy, jump in.
I think you have to try and connect with fellow ITPs, because especially those who've gone through the journey and succeeded. That was a very useful resource for me. When I came in and I was very confused, I happened to stumble across another ITP in Newfoundland. And, they'd also been challenged, but then eventually written the exam, QE1, and passed. And they were able to advise me. And that's when I took the right direction. Also mentorship, because right now, unlike when I came, we do have ITP organizations like ITPC. We have Dr. Filipe. So mentors are really helpful because they'll walk you through processes you don't understand. And then, of course, websites like CMPA, Dr. Armand pointed to that. That's basically what I can think of. Just try to get engaged with ITP communities and rely on websites like CMPA, provincial college websites as well, like College of Physicians and Surgeons Ontario. In my case, College of Physicians and Surgeons of Newfoundland. So that's something I can say.
So while I have you, Lucy, like how did you figure out what you didn't know? Was it literally other ITPs saying to you, you probably don't know this, Lucy, I'm going to tell you? Or how did you know? Because often you don't know what you don't know.
I think it was intuitive because things were not making sense. I was, referred to, certain notes or classes, and you just couldn't answer the question. It's also intuitive because usually the scammers are pressurizing you, pay up, or they're making everything look so scary. And it's until maybe I came across resources like UWorld, SQ Bank from my mentors, and everything started to click. All the questions I'll try answering in the Canada Question Bank, I was now managing to
Okay,
answer
interesting.
them. Yeah. Yeah.
Philippe?
Yeah. So thanks all for sharing those great points. I think the first thing that is really hard for us as IMGs is understanding what ethics encompasses. It's used as a blanket term that covers everything. And for us, it sounds very vague. It's very subjective. It's extremely hard. People say study ethics, and you're like, okay, first of all, what is ethics, right? It's
Mm-hmm.
kind of when people say you need to improve your communication. Like, what are you talking about? Is it how fast I'm speaking? Is it my volume? Is it the tone? Is it the choice of words? Is it like my accent? What is it like? So even we learn as educators in the medical field that when you give feedback, you need to be specific. You need to give them actionable steps to improve something, right? Selling someone to read on a topic after a difficult day is the worst feedback you can give. But if you say, the way you were holding the laryngoscope really didn't help you get a good view, I would hold it here and I would have the arm in this position. That is an actionable thing the person can do next time, right? So when we talk about ethics, what are we talking about? So I think the first thing an IMG needs to do is really get a piece of paper and start writing down everything that ethics can be and is included here before you start looking for resources, because then you can look for resources specific to those topics. So I'll give an example. We talk a lot about professionalism, communication, manager, these roles, right? So maybe a very good first place to start off is reading the CanMEDS framework that is available on Google. And that is where all these terms came from originally. And since the CanMEDS framework came in 2015, it's kind of like been set as the definition of these non-technical skills in a sense. And a lot of the medical webinars or conferences or book chapters or exams, they now have to reach these ConMeds frameworks, and they use the word professional, manager, collaborator, health advocate, all these competencies that are described in the CanMEDS framework. And that all Canadians learn intuitively what they mean because they have been trained in a system where this has been embedded for more than a decade. So if you're coming from outside of Canada, learning the CanMEDS framework is a very good place to start because there is like medical expert is one of the many abilities that you need to have. And I can say that all the other ones touch upon ethics in a way or the other. And then once you understand these roles, you start to get a better understanding of what ethics look like. And then the next step would be, in my opinion, to really list out all the topics that you can find are related to ethics before you start searching for resources that can help you better understand or improve your competency in each of them. So, for example, communicator, how do you, we can talk, communicator is a very large topic. So we can say communicating with empathy, breaking bad news, truth telling, how to communicate with a child, how to communicate with someone who is is unconscious or is not able to respond, or is limited in terms of their cognitive ability to engage into a conversation or their ability to understand and provide consent and all that stuff. So we currently, I think the biggest challenge for MG is that we lack a single resource for ethics like we have for everything else. If you want internal medicine, you get Harrison, you get Toronto Notes. There's a big chapter on internal medicine, everything organized by discipline. Ethics doesn't have that. And nobody actually can say exactly what it covers because it is fluid. It is ever evolving. Until a few years ago, Indigenous health wasn't as big as it deserves to be, and as it is slowly being represented in exams. Same with LGBTQ topics and how do you disclose, how do you respect people and work with different cultures. So this is an ever evolving field, and because it's so fluid, the MCC, for example, in its examinations, works really hard to incorporate those important topics yearly by changing MCC objectives. But for us coming from abroad, we see only like the very latest version, right? We don't know the history. We weren't here when you guys were growing and when these were being incorporated. We didn't grow in the system like the medical students and the residents did. So we have to learn the current status quo immediately. And it is really hard because we don't know where the horizon is, how far you guys have become here compared to Brazil. Our horizon there is very different, right? They might still be like years back in terms of that learning curve that you experience here. So for us, I think the future of like, or how we can improve this for MGs is really working on centralizing, first naming what ethics encompasses, like very explicitly and very in practical manner, not using terms like communication or professionalism that are, too vague, maybe specifying a little bit more, like using empathy when talking to patients, or saying, professionalism is about documentation, being very specific what you mean with these terms that are very overarching. And then I think the second part is providing resources that people can rely on to improve in each of these, so that we move away from the experience that Lucy had, which was effective, but is unreliable and variable, right? Which is relying on colleagues. Some may be extremely lucky and fortunate to have a huge network, or be in a place like I was, where I had tons of other IMGs that I could rely on. But what if you're doing a practice ready assessment in, North Saskatchewan, and you're the only IMG there? Who do you rely on? So we don't want to have to rely on the experience of others. We want to rely on trustworthy resources. And I think what we can do better in the future is to increase these resources. I think today we'll talk about some of them that we already have available. And I think as we will grow in terms of providing more and more resources around that.
Yeah, I actually want to give a shout out. My colleague Melinda just put a link to MCC resources right there in the chat. So if you haven't checked those out, I encourage you to check them out. Armand, you've been sitting quietly. I suspect you're sitting on your hands. What do you want to add something to the conversation?
I do. You're getting to know me very well. So I think I'm seeing the chat, and I certainly understand the need and the want to have more specifics. And I agree with you, Filipe, to make some things, break it down. And at the CMPA, we've certainly done that. And when you go to the Medical Council of Canada resource that's been put up there, you can certainly be directed to the CMPA, where we're put our website. We have a landing page for international medical graduates who are new to practice in Canada, or who are intending to practice in Canada. And within that, you'll find specific topics such as documentation, effective communication. What does it mean to do effective team interactions? What does it mean to do collaborative care within a Canadian context, working with other healthcare professionals, nurse practitioners, physician extenders? There are all these different professions that you have to learn to work with, or you may not have worked with in the past in your different contexts. So all of these
some of these professions we didn't even have back home. I had to learn what
right.
respiratory therapist was.
Exactly. So exactly learning to, and what is their role, and what is your role, and where do those lines start and stop, and really understanding those. So those resources are there.
And they've just been posted in the chat, by the way.
Yeah, and I think
just put a link up, so they're there now.
And I think one of the things that I think is important, though, is I would say I'm all pro that, and I think those are foundational. But there's also the context, the importance of individualization, and the fact that there isn't a book that's going to give you everything that you need to practice within the Canadian context. And I think that's the importance of making, Lucy was talking about making some of the linkages on the ground, getting some experiences, having some conversations with folks like Filipe, like Lucy, like others who've gone through the experience, to be able to then understand, what does this look like in real life? What are the different ways of navigating? And also, like, I'm going to go back. I saw a comment about, for example, within having a Canadian law book. We are different provinces. They have their own rules and regulations. And certainly when you go to the colleges, and we have colleges that regulate our practices, and they set the standard of practice within each province. If you go there and you look them up, they do have some specifics around what is the standard of practice and the ethical obligations within that province. For example, again, I saw a comment in the chat. I know I'm not supposed to respond to those, Meredith, but I'll say for about Quebec. Quebec actually does have an ethical framework. It's a medical legal ethical framework where ethics in Quebec is considered the law within the medical context, and it is clearly laid out, where you can actually read it in French or in English. It actually comes in both languages, and it tells you about some of the things that Filipe, you were pointing out to. How do you navigate consent? What does that look like? What are the pieces that you need to be informed about? What does it look like when you get into a conflict with a patient in an encounter? How do you navigate those? So some of those specifics are actually laid out through these documents. So that also does exist within the colleges that in each province, and each province has a regulatory authority that does this.
Somebody just said in the comment, the challenge of finding resources in French further complicates things. Although I know MCC and CMPA are doing their best. Sorry, Philippe, go ahead.
I was just going to say that some of these resources are out there, but it's hard to find when you're having to do your own search in each province. And I think for a lot of people that are here, and especially on this webinar that is by the MCC, and focusing on the QE1, we need to kind of start by knowing what is applicable to the vast majority of the country, because the MCC QE1 is a national exam. And for people need to understand that the exam won't go into specifics that are, about one province. So as Armand was correctly saying, there are things that are very specific to each province. They have similarities, they have differences. But I think the exam is a little bit high level in that sense, where the things that are assessed from an ethics perspective are things that are common to all the provinces and pretty much to the Canadian healthcare experience as a whole. And I think that's important because, if you start going to the provincial specifics, you can go down a rabbit hole that has no end. And I do that for licensing. But if you start doing that as well for other issues, you literally will not study anything else for the QE1, because just to understand like one long document about licensure, I have to look up many words in dictionary. I have to remember it's provincial. And then once I understand that province, I have 12 more to go. So I think it's like people need to understand first the overarching theme, like the common nomenclature, the words that are repeated out there, what do they mean? And I think like the CanMeds framework is a good start. The CMPA website, excellent resource. For people looking for a specific resource, sorry, I'm in the hospital. For people looking for a specific resource, so the MCC website recently included what they call like resource maps. So if you go there, as it was linked on the chat, they provided the link, and you click there. There are a few of important topics that encompasses what ethics looks like, such as the Indigenous health, mental health, confidentiality, truth telling, and they link you to resources from the CMPA and from other resources that are not only text but also interactive. So you might be able to find a video where someone shares their experience, and by doing this on a routine basis, in a way, like frequently, not on a crash session trying to find about ethics in a week, you need to understand that as you study for the exam, you need to be looking for these as much as you're studying for internal medicine or surgery. These are important things that will take time to learn and just as much effort as learning content about, like, specific medical content from medical textbooks. This is something you're going to need to study. It's not going to come, yes, experience will help a lot if you are doing a residency program already, if you're in a fellowship, if you got the chance to observe or contact someone else that can share that. Of course, that will expedite your learning. But if you don't have access to that, there's a lot of resources out there, and maybe it's not as organized, as centralized as we envision, and we are taking steps towards that. But it's already much better than it was before, and I think we're here to point to where these are so that people can already have a go-to in terms of resource. And then as we evolve in terms of ethics and providing more resources and more centralized will be, I think, the goal.
Okay. And wait, I want to make sure we give Lucy a chance. Lucy, I want to make sure we don't forget about you just because we can't see you. Do you want to jump in with anything?
Yeah, I think because ethics is very theory heavy. That's one thing. So like Dr. Filipe pointed out, try to simplify it. And one of the ways I tried to do that was using a book called 100 Cases by Conrad Fisher, just teaching you the basic principle, just to understand words and the meaning.
Say
And
that title
also,
one more time. Say it more slowly so we can hear it. 100.
100 Cases by
100 cases. 100 cases. Okay.
Yeah, ethics. And there are also YouTube channels on ethics. So those can help you to digest things easier, but also answering questions like OSCE scenarios. So questions that simulate the real world, because the theory is so heavy that sometimes, trying to understand it is not easy. But if you go through OSCE-like scenarios in books, then you'll get a better understanding. I think that's what I have to add to what Dr. Filipe said, which was very comprehensive.
Thank you, Lucy. Armand, did you want to weigh in?
I'm good. I'm good.
Oh, you're good.
Yeah.
All right.
Yeah.
I know that the audience, I'm getting the sense, are coming from a lot of different backgrounds. We did say something about touching on, this is the MCC, we do exams. We wanted to just spend a little bit of time on some sample exam questions, just to give the audience a chance to think about what we mean when we talk about ethics. So I'm going to ask my colleagues to put a slide up so we can have a look. And so this is available as a free practice question on our website. So I'll walk you through it, and I just briefly want to spend some time on this just to sort of give our audience a sense of an MCC QE Part 1 question, which is that a 47-year-old woman presents to your clinic for follow-up of asthma that was diagnosed 2 years ago. Despite appropriate medication, her symptoms are not well controlled. At her last visit, she mentioned that a nurse at her workplace suggested her condition may be work-related. Today, she would like you to complete the necessary forms so she can file for workers' compensation. Which of the following is the next best step? Does one of you want to sort of talk to us about like what kind of challenges? I look at the audience is going wild, giving us their best answers. But what are the kind of questions that would come up for one of you if you're looking at this and thinking, what do I need to know to even be able to understand how to answer this question? Just quickly. I can't see you all, so go ahead. Filipe, do you want to speak to this?
I was gonna ask Armand to speak first if he's
Okay.
comfortable, but I can speak as well.
Sure.
Armand, because I think from a CMPA perspective, you might have a little bit more to speak, but I can also
Sure. So I think this is a great case because the person is coming in and they have a demand, they have a request, and I think it's really important to, as we're looking at those different choices, in terms of if we're thinking about a patient-centered care and how are we looking at the patient and where are they bringing forward, I would break it down into the fact that this person is coming in with asthma that's been going on for 2 years, so they have probably a really good understanding of their illness, maybe. but I want to know more. I want to understand more. What is their understanding? And it says like they've been medicated, they've had a proper medication, and the symptoms are not well controlled. Again, you want to understand, you want to spend some time with this patient trying to understand what is going on with them, why is it not controlled, what is happening. They've also seen a nurse. So this is where what I was talking about, the collaborative nature of the work. What is the nurse doing and what is this nurse bringing to the table? So the nurse has already met with her at her workplace, suggested that the condition may be work related. So again, maybe you may want to understand what the nurse might have discussed with us, but the nurse probably has a very good knowledge of what that workplace might be like and what are the challenges that might be happening at that workplace. And she's wanting to have these forms filled out so that you can get an assessment. So the workman's compensation within it, so those who may or may not know what that means, basically are institutions within the Canadian context that look at the workers' conditions of work and if whatever they're presenting with may be caused by their workplace. So that doesn't mean that this person is necessarily going to get anything necessarily out of this exercise other than the fact that there'll be an assessment to see whether this is work related or not. So
Okay.
when we look at the choices, I think it's important. I think that we've had lots of great responses. I think this it is an audience that is well informed, and I think they've already guessed the right answer in the
Well,
choices.
interesting.
Maybe.
We've got a lot of people guessing 1, 2, and 3.
Oh yeah, well maybe not.
I'm going to ask us to move to the next slide, which does reveal the answer, which is number 1. But everything you've just said, Armand, points to the fact that there's a lot of stuff you need to understand about the context to be able to answer this properly. Everything from what is workers' compensation to, what's
exactly.
the nurse's role here?
All the different pieces are there. So this is really important in terms of just really understanding that it's not just patient comes in, asks for something. There's a lot more going on in here potentially within this case that may appear simple, but you have to break it down and really try to understand. You're absolutely right, Meredith, the bigger context of what might be going on with this patient who's presenting.
Right. So a lot of people are assuming it's number 3. Is any one of you able to just quickly tell our audience why it's not number 3? Number 3 is explain that a nurse cannot determine if asthma is work-related. I didn't mean to put you all on the spot, but we do have a lot of people wondering why it's not number 3 and why it's number 1. Anyone want to take this?
Yeah.
Lucy.
I can take that. Because as an ITP, I completely understand why they chose number 3. You're very unfamiliar with the system. And outside Canada, like usually insurance claims, workers' compensation claims are very much a burden on the physician. So you want to really explore and see if these patient symptoms are valid. But around here, you are more of a patient advocate. And workers' compensation is not really within your role. I would say it's outside you. It's administratively, it's not your role, so to speak. So your role is to support the patient as much as you can and fill in the form with whatever information you have. And then the workers' safety or insurance board or workers' compensation from whatever province will investigate and see if it's valid. So that's something that ITPs actually run into problems about. So that's what I can say.
Thanks, Lucy. Filipe, I see you turned. You've made yourself live. Let's go.
Yeah. So I think here the point is that you are not in a position to judge whether or not another healthcare professional is or is not in their role of, it's not your role to tell the patient what the nurse can or cannot do. Your role is to assess the patient and their symptoms. And here in the question, it is clear, it's not vague, that despite appropriate medication, her symptoms are not well controlled. So you as their physician, you have been following them up for asthma for 2 years. You are seeing right in front of you that they're not well controlled. And then she's asking you to fill a form. This form doesn't mean that you are signing or that you are assuming or that you are investigated and you are endorsing that it is work-related. That is not what they're asking. They're asking you to fill a form about this patient's past medical history in relation to her asthma. So you would say what her asthma has been like, that for 2 years she's been on treatment. Despite treatment, she's not feeling well. That's it. What they're looking for here is your perspective on the person that has the longitudinal care of this patient, to show a timeline that this patient has actually had asthma for 2 years. It's not new. That despite this and that treatment, they're still having this and that symptom. That is it. The causal relationship with the work, whether it's an occupational hazard or not, how that will play in terms of worker compensation, is not your role. It's someone else who's going to do that. It's also not your role to say what the nurse can or cannot say, or if she's correct or incorrect, because you don't even you don't do a site visit. You're not experienced, probably not an occupational physician or specialist. So it is not your role. Your role is really to complete the form to the best of your ability, sticking to the facts and to the patient history, and with, of course, consent of the patient in terms of what you can disclose or not, and at their request. It's the same with insurance companies. So this is something that in Brazil is very uncommon, like insurance company asking doctors to fill out reports or forms. It is not your role to say whether someone is going to be able to get disability insurance or not. If they're going to be, that is someone else who's going to do that. What they're asking you is, what is this patient's health? And if the patient consents and requests you to do that, you will stick specifically to the questions and to your knowledge as a doctor, as their doctor, and the experience that you have seen in your interaction with them in terms of their history and physical examination. Everything else is hearsay. So here, for example, the nurse saying that it's work-related. What if she said it's not work-related and she still has the form? It doesn't really matter what the nurse told the patient. The patient wants to file for work compensation. They need the information about their health. You're their physician. You provide information about their health, period. The causation, if it's an occupational hazard or not, that's not within your scope of practice.
Right. Fantastic, you guys. Just the amount of time you're able to discuss the single question and the complications and the chat going by about all the issues that are coming up here says a lot about the subtleties of what's going on in a question like this in terms of what people are expected to know. So thank you for that. Thank you for those answers. Team in the back end, I'm going to ask you to pull this slide down, and I want to just make sure we talk about the National Assessment Collaboration Examination, otherwise known as the NAC exam, before we get to questions. There are loads of questions, and they're really excellent. But I want to make sure we touch on it because it's something else where people I'm sure some of our audience are gearing up for that exam. It's delivered as an objective structured clinical examination, also known as an OSCE. And for this exam, candidates rotate through a series of 12 stations. And at each station, there's a short written statement introducing a clinical problem and outlining the candidate's tasks. Lucy, Filipe, I know you guys probably had to go through this exam. You're there, there's a standardized patient, a physician examiner is watching you, assessing you in your practice. Lucy, what do you remember about the experience of taking this exam?
It was nerve-wracking. It felt very real because it was simulating,
Right.
the real world in terms of how you'd interact with patients in Canada. And you had a very short time to display a number of skills, So, and you had to show the examiner. So you are almost acting, not really acting. Some of these skills you already have, but you have to show that you have them, basically. So, things like hand washing, informed consent, being patient-centered, having empathy, maybe empathy could be you pulling out a box of tissues to offer to the patient or putting your hand on the patient's shoulder, but of course, professionally. So it was quite nerve-wracking because not only did you have to come up with a diagnosis, but you had to display all these skills that are important for the Canadian healthcare system or context.
And again, how did you develop your skills. I think you told me you were successful in passing this one your first attempt. Is that true?
I was, yeah.
Yeah.
I
All right.
was I was much wiser this time around because with QE1, I took so many wrong directions. So with NAC, I had kind of built a community. And, I asked some of my colleagues who had passed. There were organizations like AIMGA, ITPC, they were offering free classes for you to practice. They were offering ITPs. ITPs were offering advice that were current residents. So I feel like this time I had my resources. I had the right books. Honestly, it took me, compared to QE1, where I wasted so much time, I'm even embarrassed to say, but I
Don't be
think
embarrassed. I think this audience is sympathetic. Don't be embarrassed. How much time did you waste?
oh
Tell
my God,
us.
it was terrible. I think it was like a year plus, just doing the wrong thing and then realizing that. And of course, you can't go for an exam when you're not ready. So with NAC, it took me 3 weeks just because I had the right resources, and it's quite easy if you're also experienced because then you adjust your clinical knowledge to the Canadian context. So, but that said, it was nerve-wracking, but at least if you know what to do, then you should be able to go through. Yeah.
Got it. Okay. Does anyone, Philippe, do you want to jump in there about some of the challenges that people experience when it comes to NAC around sort of these expectations of ethical and cultural competence?
Yeah, I think it's one of the things that is important for people to understand is that, because ethics is so fluid and it encompasses so many different aspects of communication, behavior, professionalism, there is no specific checklist for, a lot of the things that are assessed, but you do get a score and like an overall rating in that. And for full disclosure, I didn't do NAC myself because I didn't do residency here, but I do at University of Toronto teach clinical skills, and I've been an assessor and I've been teaching them. And one of the things that surprised me in the beginning was that when I did my OSCE exams in Brazil in my medical school, each examination room had a sink and soap. So we would perform hand washing by literally washing our hands. So when I started here and I was teaching a group of medical students, I was still a fellow in education. And I went to teach them asking in clinical skills. I was like, and there was actually a sink in the class in the room that I was teaching. They put alcohol in their hands and they sanitized their hands, and they said, okay, I performed hand washing, and they continued. And I'm like, no, you didn't perform hand washing. And there was this back and forth. And it took me a while to understand that, hand washing here, if you sanitize your hands, considered you did your hand washing. Things that are as simple as that can throw you off if you're being assessed, for example, doing an OSCE in a room that might not have a sink. You're like, how do I wash my hands? You don't know even that if you do that, it is considered adequate. Small things like that are kind of cultural. I think all physicians around the world have a sense of empathy. We get into medicine because we want to help other people. Of course, there's always a bad apple, but I think overall, all physicians naturally have that empathy towards patient. They want to help, they want to be kind, they want to be supportive. I think what we don't know, and that's where IMGs need to learn, is what that looks like for a Canadian patient. So, it's that step of saying, checking in, like, are you okay? Is there anything that you didn't understand? Does this, or just simply asking, do you agree or understand the plan? Is there anything that you would like to share about your perspective of the plan? Do you think this aligns with your goals? So like asking the patient about what you're deciding instead of just assuming that they will accept, like maybe in other cultures it would be, and learning these little questions. And I think a lot of this can, for those of you that have a chance to do an observership, be a clinical assistant for a period of time, do any kind of fellowship, I think all of this will help because you will see it in action. You will be able to observe role models, which might be just your colleagues on a regular day. But these really come at play because once you see and you understand, it is natural for you to repeat because we are empathetic by nature. We just don't know what the patient is looking for, what is expected of us, and the best way to do that. And I think that if a Canadian physician, a very competent one, went to Brazil, even if they already, for example, knew Portuguese, it would take them a while to understand that, maybe disclosing every single risk is not ideal in that culture. You might need to take it step by step. You might need, 2 or 3 encounters with the patient until you tell them every single risk of what's coming with chemotherapy, because you don't want them to also disengage on treatment. While here, to decide on the treatment, they might want all that information up front. So it is about learning those nuances. And I think on NAC, you will be assessed on this by the overall component of how well you performed on the whole case. So if you present yourself, if you do hand washing, all these things, although they're not on the checklist, they are extremely important on your overall score, which might be just as much as important as the checklist itself.
And I think it's important to stress to people that knowledge of the Canadian system comes into play. For example, in a NAC setting, they're told that the scenario they're about to encounter is taking place in, say, a more remote part of the country. In a country as big as Canada, the experience of practicing in a big city versus a remote location is going to change the recommendation, presumably. And how do people know things like that?
Yes, I think you need to take into consideration that it is not expected of you to have every single answer, like exactly what will be the process, what will be the form. That is not what's being assessed here. It's about the fact that you would take into consideration that, if it's something that can potentially become urgent, you want to anticipate the need. You might want to send this patient or request a transfer early on, knowing that you can't simply just tell them what are the red flag symptoms and assuming as if they're downtown Toronto, or if they have a chest pain, they can simply go across the street and they're at St. Mike's where I work. But you might need to tell them, you are at a significant risk for this or that. And although right now it is, not urgent, and in a patient that has easy access to tertiary care, we would maybe just observe and tell them to seek help if needed. In this situation, if it becomes urgent, it would maybe be not safe for you to wait for transfer. So you might want to consider doing that earlier on, and having that kind of sensibility around access. And this also touches with, for example, Indigenous health, where you need to understand where their culture intersects with our what we propose as a plan, or if we are able to find a common ground that, we are able to do what we think is best in terms of care plan, keeping their culture, their beliefs still at play. And a lot of these communities are under-resourced. They are distant, right? So they're already at a disadvantage in terms of how much care they can access. So we as healthcare providers, and if you're in a station, a NAC station, where you're treating a patient in this situation, you need to show that you are empathetic of that and that you are taking that into consideration when proposing a plan. You can't simply say, if you have chest pain, you can come back within an hour. That is not taking into consideration the reality that these people do not have that resource within reach, 1 hour reach, right? So that's what's expected of the IMGs, or not only IMGs, of the physicians going through a question, for example, at NAC.
Okay. Thanks all of you. I want to take some audience questions, unless anyone needs to really jump in on the NAC QE1 questions we were talking about. Otherwise, I want to put this one to you, which is a great and interesting question. And Lucy, it may be relevant for you in your some of your prep work that you did when you came to Canada. The question is there a big difference between Canadian and US ethics? If we are studying US ethics, is most or all of that knowledge transferable to Canadian exams?
Okay.
Anyone want to take that? Lucy?
I can take it. So I'm going to be very honest. US resources are more comprehensive and more structured. But the Canadian context differs in many cases. So sometimes when you need to understand a topic that's really confusing, there's a very famous question bank called UWorld, you know? It can help just to help you gain an understanding, but you have to come back to the Canadian resources to really understand the laws here, because not every law there applies here. There are similarities for sure, but it operates differently. So you have to be wise in the way you go about it. That's what I can say.
Yeah, Armand?
Meredith, I feel like
Yeah.
I feel like
Yeah,
an
you're
obligation
poised.
to
Let's do this.
I have to say something. So I practiced in the United States for 5 years, and I practiced already 5 years in Canada, and then I moved to the United States to in Southern California to practice there. And I have to tell you, I felt very confused because I spoke the language and I practiced many things were similar, as Lucy said, but there were many differences. And I actually felt like I'm going to say, not quite maybe in a tertiary medical graduate coming to a Canadian context from a very different country or a different context, but certainly there were fundamental differences in terms of even patient-doctor relationship and what does that look like and how we approach medical care and practice within the Canadian context. Very different geography, very different resourcing, very different availabilities, rules and laws and approach from a medical legal standpoint, from consent, what does that look like? So I would caution that we should be really thinking, maybe not as well organized, and absolutely there are some maybe similarities, but I would say that we should be staying within the Canadian context and resources for the most part, because there are significant differences between the two countries.
If I
Okay.
can add,
Yeah.
one of the things that is very different is that we are in a universal healthcare system that is public healthcare, and the US is very much private insurance. So there are a lot of things that are administrative process and things that are expected of physician in a private healthcare setting that might not apply here. And the opposite is true. There's a lot of things that are expected in a public healthcare setting that is not expected in the private healthcare setting. So I think it's an important difference. And I have, for example, been in touch with physicians that come to Canada that have worked in the US, and they're surprised about certain things we do here, and I'm surprised about certain things they do there. And they will frequently tell me like, oh, in the US, we can't do this. Like, we need to do it this way because the insurances or will not, do this or that. And here our focus is might be different. So I think these are important considerations to take when you're preparing for the QE1, because it is focused on the Canadian healthcare system. And I saw someone in the chat, even though you always tell us not to read the chat.
I don't want you to be distracted by the chat, but the chat is a rich source of information.
One of the things that caught my attention is just that, people are saying like, oh, then the QE1 should not assess ethics, and because each province can be different. And I absolutely disagree with that, because I think there's the number of things that are common across all provinces is much larger than the specifics of each province. And the QE1 is not looking to assess people on the specifics of each province. But these other issues, or not issues, these other topics, the important topics such as confidentiality, privacy, empathy, effective communication, all these things are expected no matter where you go to practice in Canada. And the QE1 has just as much as it has this important role of assessing that you have a knowledge that for medical content that meets a standard. It also needs to ensure that your knowledge meets that same standard when it comes to ethical, the use of ethics in medical practice.
Okay, super. Oh, Armand, do you want to weigh in? Because you are muted.
Goodness, I knew I would have done. Okay, I wanted to jump in for just one thing. There's something that Filipe was talking about it just a little bit earlier on about an approach with a patient and how you're talking to a patient, and when we're gathering some of the at the end of a visit, talking about, do they understand issues? And somewhat what we're hearing today may make it sound like it's really complicated and complex and can be actually kind of a little scary when you're hearing that. I think one of the things that is really, and I'm going to use a bit of a personal experience, is something we're also seeing with at the CMPA. We're hearing a lot is the question of what are your expectations? Just when you meet a patient, to say, what do you expect from this visit? Why are you here? And really being curious and interested and having that as the opening and going from there makes a huge difference. There's some, basic questions. Did you understand what we talked about? Did I address everything that you came here for? Can you tell me what you understood today and what are the main points that you're walking away from? Is there something we can follow up with again? There's some very basic fundamental things that are universal across every province, every system. And I think that to think of those, and that they don't sound very complicated, but they're important and they can get you in, even during exam stations. If you have that approach, can get you to a good place. So I wanted to just bring that out, that it doesn't have to be super complicated either in terms of how
Okay,
you think about it and approach it. Thank you.
that's great. Thanks. We have a lot of questions, and some of them are quite specific. And I said that we wouldn't get really too specific, but I want to put this one to you guys. Um, Somebody's saying, could we talk about abortion in Canada? What is the root of care? Is it legal in all scenarios? Is there conscientious objection for doctors who, for personal or religious reasons, cannot perform an abortion? How does it work? Probably this is a big topic that is different to different cultures and countries. Thanks in advance. I know I said we wouldn't get specific, but I want to get specific on this one because there are issues in Canada. We have medical assisted dying. There are things in Canada that maybe people haven't encountered in their own countries. Um, how do you learn what you need to learn to handle these topics?
So I'll just start by saying this is a great example of how ethics, when you're studying, so like I usually recommend Toronto Notes because it is a review source that is Canadian. And for example, termination of pregnancy is in the chapter for obstetrics and gynecology. However, it is a deeply rooted ethical concept and concern. So people that try to say like, oh, but ethics is only like the ethics chapter on turnovers is very short. Well, that's just the main concepts. And then a lot of it, such as elder abuse, child abuse, sexual abuse, they will be in other chapters. And it's not because, Toronto Notes doesn't unite them in a single chapter that it's not ethics. Answering your question, there are many nuances around termination of pregnancy. So I'll give you an example. I work in a Catholic hospital where here we do not in this hospital perform termination of pregnancy. However, we have the responsibility of referring patients to services that provide that. And at those hospitals where those services are provided, the physicians have the legal obligation of telling the patients their rights, despite their own beliefs. They should not share their beliefs because it does not matter it's a patient-centered care. Your role is to tell the patient what are their options. Termination of pregnancy is an option within certain guardrails and limits in Canada. And if you are unhappy or not unhappy, sorry, that was a bad choice of words. If you are uncomfortable or you do not feel that performing a procedure aligns with your own beliefs, you can excuse yourself from doing the procedure as long as you refer the patient to another healthcare professional that takes over the responsibility of care and will then be responsible for providing that service or referring the patient to someone who provides that service. So it's not your role to educate the patient about their beliefs. It's not your role to share your beliefs or be judgmental in any way. It's your role to tell the patient what are the options available, which includes the possibility of termination of pregnancy and where those services are provided. And I'm sure that, there's a multitude of For people that work in healthcare, they would know, like if you are in a primary care, you would refer them to obstetrics gynecologist specialist. If you are in the hospital in the ER, you will know who to refer to. And your role is really, that's the type of thing that the QE1 is would ask. Like, would you share your belief? Would you try to educate the patient? Would you simply tell the patient that you can't do it because you don't agree with it, and according to it doesn't align with your belief, and end it there? Like, it's your responsibility to know that while you can't share your belief and that you are not there to educate the patient, that you need to make sure that the patient knows the options available and they have all the information they need to access that care if they choose to do so.
Anyone else want to weigh in?
I'm just going to jump in and just say, excellent answer, Filipe. I agree with you. I would extend those principles, and I think you just pointed at some principles around. You use abortion as the topic, but the same would apply to gender affirming care. The same would apply to medically assisted dying. All of those would be similar topics that you may feel exactly. I won't repeat everything Filipe said, but it would be the same approach and principle. Those are the kind of commonalities that you see all throughout Canada, and those are the commonalities within our ethical framework and our approach.
Got it. Lucy, do you want to weigh in? Sorry, Filipe.
I know I want to hear Lucy. I just want to mention that this is another good example of things that are consistent across provinces and how provincial variations do not have, like, still can exist, but these main principles are consistent. And these are things that might be extremely different in other countries. So if you are studying, for another exam in a different country, what you might come across in textbooks might not really align with what is expected of you on the examinations here in Canada.
Lucy.
I think Dr. Filipe and Dr. Aalamian have answered that question comprehensively. And, I just want to add that maybe coming from a conservative background, some ITPs do, it's really important to be humble and open to learning and not to allow your bias and ego to, influence your interaction with patients. Like, don't be judgmental, don't be dismissive, be neutral, and always be patient-centered, and always be willing to do what's best for them. So like Dr. Filipe said, if you don't do abortions, then refer them to someone who can.
Okay, super. I want to make sure that our audience feels well equipped with knowing where to go with resources. I know we've been talking about lots of different resources over the course of the last hour and a bit. So just sort of once and for all, we just want to make sure that the audience knows what's what. Armand, do you want to just make sure, like, how can CMPA support this audience? What should they be looking for from you?
Absolutely. So, like I said, it's really easy. Just the abbreviations. Put in whatever search engine you're using. Put CMPA IMG, or you can go to the Medical Council of Canada website. We're also referenced there. We provide that landing page where we have the resources. They're free of charge. We're a nonprofit organization, and you don't have to be even a member to go there and to be navigating and doing these learning activities. And they are addressing many of the issues that we've talked about today, and they've been basically endorsed through the different national organizations, and also data driven. So those are great resources, and like I said, they are also specific, like Filipe was talking about. They're not sort of these general pie in the sky type of things, but they're specifically, these are the things that you need to be thinking about and know about.
Okay, super. Filipe, you want to jump in? We've got lots of MCC resources, which we have been sharing. I just want to make sure the audience knows, when you get the recording, which you will be getting in your email, you're also going to get some resources. We're going to point to some of these. I just want to highlight them. Filipe, anything you want to make sure people know?
So you're asking me to focus specifically on resources?
No. Well,
No?
hey, you talk to me about what you want to talk about. Let's go.
Okay. So I think what IMGs want is practical next steps. I think what you said is really important. You guys will get a guide by email. That's number one. Number two, make sure you cover two main resources: the MCC resource maps that has all the free resources there, and the CMPA ITP or IMG hub, which has a lot of resources there, and the CanMeds framework. If you do those three, plus the information available like on Toronto Notes, for example, you already have a lot of your bases covered. So I think a lot of people get stressed because there is no limit to research on the internet, right? You can Google anything and it's like you go down the rabbit hole. It's like scrolling at night. You won't stop until you put your phone away or the battery dies. Like you really will not stop. There's no end, right? There's no end to the feed on Instagram. And if you start Googling ethics and you click, you're never going to end. It's never going to end. And it feels overwhelming. You feel like you're never going to achieve, you're never going to have that knowledge. So start by putting realistic objectives that are achievable. So going through 4 or 5 resource maps on the MCC website and all the resources listed there, that's very attainable. Going through the CMPA website and read the articles listed there, very objective and attainable. Read the CanMeds framework, very objective and attainable, and read the ethics chapter on Toronto Notes, plus these chapters that are in other specialties that relate to ethics, such as elderly abuse, child abuse, and for example, termination of pregnancy. If you do these 4 resources, you are already way ahead of the game.
Okay.
And then after that, if you want to fine tune, you want to go extra, you can get the Doing It Right book. You can go on the rabbit hole of the internet, Google ethics, and go down there and never stop. But a lot of people do that, not only with ethics, with a lot of topics. They start Googling, they go to YouTube, and then one video leads to the other, that leads to the other. And then after they're 3 hours, and they end up on a video about, buying a bathtub that had nothing to do with the sarcoidosis where, they started off with.
Yeah.
And like, it's just completely, it's really hard. Like you won't be able to really stick to your plan. You need to have a very specific plan and focus on achieving that and feel successful. And you are going to have most of the resources you need. You can always fine tune better, but it's important to have a realistic goal, because I think a lot of people feel frozen and don't take action and just complain. Ethics too hard. I don't know where to find it, but we're giving you 4 places. Do these 4. And after you completed these 4, you can come back and complain if they don't match your expectations. Do not say, I don't have resource if you didn't even cover the 4 basic ones.
Okay, I want to mention
a bathtub.
Yeah, you might end up buying a bathtub. I want to make sure people know about where they would learn more about communication skills. As you talked about at the top, Armand, the general challenge of like improving your communication skills. Are there resources we recommend when it comes to improving communication skills?
Yeah, so the resources that when you go on the web, on the CMPA website, we have specific resources and electronic learning activities, in fact, which you can engage with. You can actually do stuff where you're practicing communication skills and communication issues. So you can absolutely do that.
I also want to mention I know about the National Healthcare Language Program. We can put a link to that in the chat. That's lots of resources there too. Lucy, I'm not meaning to leave you out. Is there anything you want to add in terms of resources?
Definitely Canadian Medical Protective Association, CMPA, very comprehensive. College of Family Physicians of Canada practice guidelines. And then ITPC offers videos as well. Once you sign up for a membership, it will guide you through the licensing process and you'll come across many of these topics. Plus the provincial colleges as well. So,
all right, so nobody will waste money like you did, is what we're saying, Lucy.
No. Mine was a terrible experience, so no.
Okay. And there are lots of people asking in the chat about these resources. As I say, so they are being shared, but also you're going to be getting an email with the recording and links to a lot of these resources in the days to follow. We've got 5 minutes left on our scheduled webinar. I like to leave the audience always feeling kind of hopeful. I think we've seen some comments that people are feeling a little bit hopeful. But if you had a final piece of advice or encouragement that you wanted to leave the audience with, what would it be? Armand, you look poised and ready to give our audience some encouraging advice.
I'm going to maybe I'll give the advice in a second, but I'm going to talk about one thing that is really encouraging for me.
Okay.
The fact that we are here today, the organizations that are here today, is really encouraging. So, the Royal College, the College of Family Physicians, MCC, CMPA, we're working together, advocating at different levels in Canada to really try to navigate this challenging, make it easier for folks to integrate into the Canadian context and to understand these complex issues. So I want to reassure you that we get it and we are on it. And people like Lucy, people like Filipe, who are fantastic colleagues, are trailblazers, and we get that. So I think that's really important as a message for you to walk away with. And I think my last piece of advice, we've given you lots of things. Go to those resources and think about what you would like to receive as care. Think of yourself as a patient and think of that, how that would feel, how you want to be treated, and build it from there. It doesn't have to be complicated. These concepts don't have to be super complicated. Back over to Filipe. I'll pass it to you.
Yeah, I think that there is two ways to see things. You can always see like I don't know if this is the same in English, probably it is, and I'm not going to say it in the right way because my Brazilian background, but like you can always see the cup of water half full or half empty, right? And I think that the half empty would be people just saying like we need more resource, not centralized, which we all know, we agree. But the half full is we have never been where we are now, where we are trying to like talk about this. These resources are trying to be created. We are literally paying attention and hearing that we need more resources to help people get there. And the resources are starting to build up. So it's not because we're not in the perfect scenario that we have not made a lot of progress. So for IMGs, to first be at peace with ethics, because you need to make peace with it, accept that we have, improved and that we might be far from ideal, but we are way better than it was before. And that reality is reality and life is hard. I say there's all the people are like, how to learn ethics easily. Nothing is easy in life. Life is really hard. And things that are easy are usually not worth it, right? So if you want to learn ethics, it's gonna be hard. But we do have a lot of resources that are available. Make use of the resources available instead of just keep complaining that it's not perfect. And acknowledge that the imperfect as it is right now, it's so much better than it was. So let's celebrate the wins, use the resources that were recently created by CMPA, by MCC that are available, and do the best with those resources. And I guarantee you that if you use these, like I mentioned, they might not be centralized. They might not be with the most didactic, educational, easy to read language, but they are efficient and they will get you past the finish line. So have very achievable, attainable objectives, focus on them, and do not, like my number one advice, do not go down the rabbit hole of just searching things randomly without like any kind of purpose or plan. And this goes beyond ethics, preparing for any exam in your life, any kind of task. You really want to have a plan. Like nobody starts like, oh, I want to lose weight, and they start running anywhere and lifting any kind of weight and just like, oh, I want, like, you need to have a plan. You will go consistently to the gym. You're going to have a certain number of exercises you're going to do for a certain number of time. For 15 minutes, half an hour, 1 hour a day, it's the same, right? Have an objective, be consistent, and use the resources that are available, and try to see the cup half full, because you will get there.
Thanks. Lucy, quickly, anything you want to add?
I would just want to add that, unlike when I came, there's plenty of resources today that are reliable. I'll talk about provincial bridging programs and IMG bridging I think almost every province right now has a bridging program for ITPs. For example, AMGA or ISANS, and then there's the Internationally Trained Physicians of Canada, where I come from. We're there to hold your hand, to give simulations. So the journey is complex, but it's made easier. You have MCC right now, you have CMPA, so there is hope. And even as much as I struggled with resources, I was able to pass both exams with the first try. So if I can do it, you can do it.
Amazing. Okay. I'm going to wrap us there because we are at time. I want to again assure our audience that yes, indeed, a recording is coming. You'll have it in your inbox in a few days. You'll also have lots of links. I want to make sure that everybody knows that there's been a team of MCC people behind the scenes helping with this. So I'm going to get my colleagues to turn on their cameras. So when you guys have been wondering who the heck is answering these questions, we have a great team of MCC people. So we've got a couple of our colleagues. They're all behind the scenes. Thank you to Catherine, Melinda, Stephanie, Marike, Cecile, Zainab behind the scenes. And then a special huge thanks to our panel, Armand, Filipe, and Lucy. Sorry we didn't get to look at you, Lucy, but we were so happy that we could hear you. And so thanks again and also to our fantastic audience. We really appreciate your engagement and we hope we've been helpful. We're here to support. So thanks very much, everybody. And we'll see you again soon, I am sure.